Hi, I'm Chuck Lanzarotti. Thank Dr. Feifel for inviting me to speak about screening for sudden death in athletes or cardiac screening of athletes. I am the electrophysiologist, cardiologist, electrophysiologist here in Milwaukee. I work for Wheaton. I'm the medical director for the EP group here. And this has always been one of my interests in EP. We deal with heart arrhythmias, sudden death, so this naturally falls into our area, and I'm very happy to speak about this. Sudden death in athletes dates back to the ancient Greeks in 490. Those of you who are familiar with marathon running know that the distance between Marathon and Athens is 26 miles, and the length of a marathon course. And that dates back to 490, when after the Battle of Marathon, when the Greeks defeated the Persians, a messenger was sent running to Athens to give word of the victory, and basically, as the story goes, said that they won and then collapsed and died. And so this is probably our first recorded episode of an athlete dying suddenly. In my time, when I was in medical school, Hank Gathers was a famous basketball player, college basketball player, who collapsed and died during a televised game between his team, Loyola Marymount, and UC Santa Barbara. He had actually had a well-publicized issue because he had collapsed earlier during another game, had seen physicians, was diagnosed with a more benign type of arrhythmia, was allowed to continue to play, and then tragically died suddenly on a televised event. At autopsy, he was found to have a hypertrophic cardiomyopathy. A couple years later, an even more famous case was Reggie Lewis, who was a Boston Celtic. There's some controversy I won't get into about maybe some other issues in Reggie's lifestyle, but nonetheless, he had, again, a very well-televised and famous collapse during a playoff game, and famously sought the advice of an internationally renowned cardiologist at Harvard, being that he was a Boston player, and was allowed to play, and then a few months later during a practice session died suddenly. And in that case, he was also diagnosed with a cardiomyopathy, and there were other issues regarding his compliance with meds and some other issues, so it wasn't all that clean, but nonetheless, this is another, I think we're back at that era, it came to light, the issue of sudden death in athletes. It's a very rare event, sudden death of an athlete, but it's particularly if you're dealing with a child or a high school level athlete, this is a very tragic event. Usually, it does happen, unfortunately, very commonly, about 100 times a year, and it does usually make the news, so we're all very familiar with seeing some unfortunate child. Usually these days, with between video cameras on phones and whatnot, it's usually one way or another, whether it's televised or whatnot, it's filmed, and it's always a very sudden, tragic event. The risk to an athlete, all comers I should say, is about 1 in 200,000. Most of these athletes have a preventable, treatable illness if screened properly. Unfortunately, I'll get into, it's a bigger problem than just simply saying that it could be preventable, but most of these athletes will have some sort of diagnosed condition after the fact. The issue is getting to the person before the fact. But nonetheless, logically, if we can do a effective screening and prevent any of these deaths, particularly in high school, young, vibrant people, we certainly want to do so. It really, in the world, the type of sport associated with sudden death relates more to where you are in the world. So in the United States, where we play a lot of football, play basketball, those are our competitive sports. Those are most commonly about 2/3 of sudden deaths occur during those types of sports. In the rest of the world, soccer obviously is more common. That's the competitive sport, and that's where you see sudden death. And therefore, really, the risk of sudden death increases with the level of competitiveness. You don't see many bowlers dying suddenly, but soccer players and basketball players particularly, you will. When you get to the highly competitive elite athlete, which we're really not talking about here, sudden death risk increases. And again, I'm kind of dumbing this down a little bit. When you're dealing with elite athletes, there's a whole different set of issues, and particularly in the NBA, where the risk of sudden death is probably the highest. These are also certain types of individuals, so it's not your typical high school athlete. Really, sudden death can occur from cardiac cause from pretty much any type of heart condition, be it anomalous coronary arteries, thickened myocardium, valve disease, infection in the heart, inflammation in the heart, or conduction abnormalities. And we'll kind of touch on these big picture just to give you a little flavor of what's out there from my standpoint is in the field of electrophysiology. Looking at all comers again, the majority of patients have hypertrophic cardiomyopathy. That's about a third. I won't say the majority, but the majority, largest number of patients, I should say. A third to probably 40% if you take patients who are kind of not really intermediate. They might have LVH, maybe not definitively diagnosed with hypertrophic cardiomyopathy. The next common would be anomalies of the coronary arteries, and then pretty much everything else. The problem we have in the United States, and we'll get into this a little bit later when we talk about what's being done in other parts of the world, is it's a big country, and many of us like to, our children compete in high school and other intramural athletics, and therefore you have roughly 5 million, probably more, student athletes competing, so this is a big cohort of people to screen. When you get to the collegiate level, there's still about 500,000. And then obviously, the professionals screen themselves, but all comers, the problem is that these are very rare conditions. They only occur in about 0.3% of the population. So literally, you're screening a large number of people for a very small problem. But again, the issue is, because of so many people competing, and just the fact that these diseases do occur in the population, you're going to have a certain number, if you do no screening, a certain number of athletes will have these conditions and will die. So that's the problem we have, is what to do about that. Again, the most common cause is going to be some sort of congenital abnormality, be it hypertrophic cardiomyopathy, which we'll talk about, or congenital anomalous coronary arteries. Most of these people will not have any really definable symptoms, particularly an athlete. It's going to be very difficult to determine if they're having symptoms or not. They're not going to have anything discernible other than maybe some shortness of breath with exertion or other things that'll be hard to determine if that's a training issue or truly a problem. If patients do develop symptoms such as passing out while exercising, obviously that's a red flag and needs to be addressed. We've talked a little bit about hypertrophic cardiomyopathy. That's probably, again, the most common cause of sudden death, particularly in the highly competitive athletes, the basketball players, the football players. The sarcomere, which is the unit inside the myofibril or the heart muscle cell, enlarges, which enlarges the heart muscle cell, enlarges the heart in general. Unfortunately, also, as these heart muscles enlarge, they don't line up the way they normally should in a proper pattern. And because this, what we call myocardial disarray, occurs, this increases the risk for electrical abnormalities, which causes the heart arrhythmias and the sudden death. So they have two different ways they can actually collapse. One would be from just an outflow obstruction, meaning blood just can't get out of the heart because the heart's so thick, or the actually more common where a heart arrhythmia occurs. This is a genetic disorder that can be screened. Unfortunately, like many of these we'll talk about, there's over 150 different genetic abnormalities, and when you do send someone for genetic screening, in general, it's very expensive. Often insurances won't pay for it. And more importantly, they'll screen for the most common genotypes, but if you have 150 different genotypes and they screen for maybe 10 or 15, obviously you're going to miss quite a few. So genetic testing is nice to do. Again, it takes a while to get the results, and often even if you get a negative result, that doesn't mean the patient's in the clear. That just means they don't have one of the more common types. So in general, that's one of the issues with, at least state of the art now, genetic testing. As we refine this over the years, that'll change in the next hopefully years to decades. The prevalence, again, is very low. It's only 0.2 to 0.5% of the population. So again, what you have is a normal heart here in the top right. Would just, obviously the heart's going to thicken, and we'll talk quite a bit about athletes, and an athletic heart does thicken. It's just like their muscles, their skeletal muscles will thicken, their heart will thicken depending on the sport they're in. But with a hypertrophy, congenital hypertrophy or hypertrophic cardiomyopathy, there will be abnormal hypertrophy, abnormal thickening of the heart, and usually in specific places, which can cause the heart to have a difficult time filling, pumping, and getting blood out of the heart. These people do have abnormal studies when screened. They'll have usually a very abnormal EKG with, sometimes it'll look like what's called an LVH pattern or hypertrophy, but often they'll have evidence of looking like possibly mimicking a heart attack or an old heart attack, an MI. An echocardiogram, which is an ultrasound of the heart, they'll have evidence of possibly what we call outflow traffic obstruction, meaning the heart has an inability to push the blood out due to such thickening. If you do send them to highly advanced screening like a MRI, they'll show fibrosis. Now, a normal athlete's not going to have scarring in their heart, whereas these patients will have evidence of the heart's fibrosing over, which is obviously a pathologic sign and not something you see in a normal weightlifter. And getting forward, even more advanced scanning, PET scanning, or if you do monitoring on some of these patients, you'll find abnormal rhythms that you wouldn't see in the general population. If we do find someone with hypertrophic cardiomyopathy, we can stratify the risk for sudden death. Generally, probably none of them are going to be allowed to play in a sport if they have this condition, or a competitive sport. But if they're diagnosed at a young age, particularly if they've had any syncope, which is passing out, if they've had syncope with exercise particularly, that would be a bad sign. But generally in our business, anyone who's passed out with a hypertrophic cardiomyopathy, we presume the worst. We presume it may have been an aborted sudden death episode and treat them as such. Particularly if a patient does have a family history of sudden death and cardiomyopathy, that patient is at a very high risk of herself having sudden death. On echo, if they have a very thick wall, that would also predispose them, or arrhythmias noted on monitoring. So when we do get the patient, we could pre-screen them for, really what we're looking at in my business is, do they need a defibrillator, or what is the risk to family members of sudden death? And that's sometimes where genetic screening is more important, is if you're trying to find out that patient has a problem, should we screen their children or brothers and sisters and whatnot. Second most common cause is anomalous coronary arteries. Normally, if you look at the top right picture, the aorta is the blood vessel that comes out of your heart. Your arteries that supply your heart pop right out of the aorta, and they come out on either side, the left and right side of the aorta. The problem is with anomalous coronary arteries, both arteries come out of the right side, and then if you look at the bottom right picture, the left coronary will move between the groove between the aorta and another large vessel called the pulmonary trunk, which is the blood vessels going to the lung. And the issue is that if somebody's exercising, both of these vessels will dilate and squeeze the artery, which will more or less mimic a heart attack because that artery will be squeezed. So during exertion, the patient will get ischemia or a lack of blood flow to the muscle, and that could cause essentially a heart attack or ischemia or sudden death. So that's in patient. There are many other coronary anomalies. This is the only one that can essentially kill somebody while they're exercising. A little more esoteric, but still it does occur. It's something that easily screened for actually with an EKG is arrhythmogenic RV Dysplasia. That's simply where the right ventricle or the bottom right chamber of the heart becomes infiltrated with fat and fibrous tissue. The issue is not so much the ventricle, because the ventricle continues to work, maybe not as well, but we don't really depend on our right ventricle. The problem is that these fatty infiltrates can lead to arrhythmias and lethal arrhythmias. And this can be screened with an EKG, MRI, echo, many of the things we talked about. On the right, you see a picture of an MRI showing fat infiltrating the wall of the right ventricle. And this is just an EKG. We don't have to get into details, but up on the what's called, for physicians room V1, has a little notching we call the Epsilon wave. So it's something that it's subtle, but can be picked up just with a simple EKG. Wolff Parkinson White is something I deal with routinely. That's where the top and bottom chambers of the heart connect with an extra wire. This can cause problems for athletes, usually in a nuisance sense, in that it'll cause what we call a supraventricular arrhythmia or racing heart rate syndrome. It can lead also to another disease called atrial fibrillation, where the heart can beat chaotically and very rapidly. The problem is in some patients, about 0.6% of the patients, so a very low number of a very low number, because only really less than 1% of the population has this problem. But in less than 1% of these patients can develop a very lethal arrhythmia and die suddenly. So this is also something that can be screened for easily with an EKG, and more importantly can be easily treated with a catheter ablation, which is really a one-day outpatient procedure which would cure the patient and let them get back to whatever sports or else they'd like to do in life. So on the left you see a typical EKG. On the right, where we see fusion, what's called the delta wave on the right, just showing that in the normal cardiac conduction would be through the AV node, and then someone might have, it could be anywhere in the heart, but they'll have an accessory pathway which would lead to conduction through two areas of the heart, which could lead to chaotic either atrial fibrillation or rapid racing hearts. So on the left we see, this is for any emergency department physician, the worst thing they'd ever want to see, which is a Wolff-Parkinson-White patient in atrial fibrillation. And the last thing they'd want to do is what they normally would do, which is give a drug to slow down the heart, a beta blocker or a calcium channel blocker, because in these patients that could actually put them into fibrillation or a lethal arrhythmia. Actually here at Franklin, I just saw a patient like this right over Christmas break. Was a football player, came in with this type of arrhythmia. Fortunately, he had his cardiac arrest in the ED here, and he was successfully ablated and is actually back at sports. So it's a common problem in the big picture, and it can be cured. Also can be lethal, so again, something easily screened for just with a baseline EKG. Brugada is something that is getting more and more attention really over the last decade. When I was in med school, you never heard of it. And then over the last 20 years, it's come to be much more commonly recognized. Also can be diagnosed with a screening EKG. It's more common in males from certain parts of the world. Nonetheless, it's usually due to a genetic abnormality, but about half the time it could be a spontaneous mutation, so the patient may have no family history. These people will have structurally normal hearts, but they'll have an abnormal EKG. Usually we're going to be looking for someone who's either had abnormal arrhythmias or, again, syncope, which is passing out, or an aborted sudden death episode. EKG screening is usually helpful, but these patients don't respond well to drugs and usually will need a defibrillator and certainly wouldn't be candidates to play in any type of sport. Typically, they'll have a EKG that's easily recognizable, where it looks almost like an acute heart attack, and what we call the anterior leads of the heart have ST elevation. So sometimes they're misdiagnosed when they present to an emergency department as having a heart attack, but quickly it's determined that that's not the case. Long QT syndrome has been around a very long time. It's a common problem. It's a genetic problem. It affects, more commonly really than the genetic issue is congenital issue is drug use. Many drugs, when you hear about a certain drug causing sudden death, like the erythromycin type antibiotics, it's due to abnormal prolongation of the QT. So someone may have a predisposition for it, and then the drug unmasks it. Some patients, just the drug alone can do it. Some of the antidepressants can do this. Nonetheless, whether the patient has it from a drug they're on or from a congenital abnormality, it can cause sudden death, and in certain types with exertion. So they may have a normal EKG at baseline, but when they exert themselves, what's called the QT will prolong. And these patients, again, are stratified based on their symptoms, family history, EKG, and sometimes more invasive tests. So your typical patient would have a family history, and as we say, typically some of the classic example would be a swimmer or someone who's startled, has either seizures. Sometimes these patients have history of seizure, and it's actually not a seizure they're having, it's a sudden death episode, but they're young and their heart's otherwise structurally normal, so they recover. They pass, and it looks, because there's no blood flow to the brain, they actually do have a seizure, but they're misdiagnosed with seizure disorder, and actually it's a congenital heart problem. I want to talk a little bit about Commotio Cordis because it is something we do see. Typically, you'll hear about a little leaguer who has a line drive, usually the pitcher, hit with the line drive in the chest and drops over dead. These patients actually have completely normal hearts, these kids, and it's just really an anomaly, a freak accident more or less of the projectile hitting their chest at the precise time to trigger ventricular fibrillation. It's not a problem with their heart. It's not something you could really screen for. It's just something to know about, and that's why one of the many reasons we recommend AEDs where there's athletic sports going on, particularly in the case of something where you're using hard projectiles, because essentially what happens is there's an impact on a vulnerable part of the T wave on the EKG, which we call the R&T phenomenon in medicine or cardiology. But what happens is in a particularly young male, they have a very elastic chest wall, so that projectile hits the chest, bounces off their heart, and triggers the fibrillation. As they have a normal heart, they can be completely saved with a defibrillator. There's no, unlike sometimes a patient with hypertrophic cardiomyopathy, where once that patient begins to have their problem, defibrillator may not help because of their thickened heart But in a patient like this, it's a patient with completely normal heart, so it's reversible, and it's not preventable by any kind of screening, which is my point here. It's more or less, it could be, again, just like we talked about, soccer versus football. It depends on the part of the world, the type of sport, but any hard projectile or even a critically timed hard punch to the chest could cause this problem. And once it occurs, the only way to stop it is to defibrillate the child. So here in the United States, we followed American Heart Association guidelines, which are a comprehensive 12-step approach to screening patients, screening athletes, I should say. It's primarily a history and a very limited directed physical. The problem with this is, for all of the issues we've talked about, it's not all that effective. You will find some patients, but the majority of the problems we've talked about aren't detectable on a physical exam, and particularly the most dangerous. But again, you're looking for a history of exertional chest pain or syncope. Syncope with exercise is really the key. That is, something's wrong if an athlete's passing out while running, versus blacking out maybe 5 or 10 minutes after they've cooled down. That can be more of what we call a vagal event. But in the middle of high adrenaline state, if they're passing out, it should be investigated quickly. Again, we look at the family history, and we've talked quite a bit about this already. Really what we're looking for with family history is any of the problems we talked about. Do they have a known history in the family of long QT syndrome or cardiomyopathy, anything? Obviously that would warrant probably a closer look before we let them get into the competition. Physical exam primarily is directed to look for a heart murmur, but most of the problems we've talked about, most of the common causes, myopathies and whatnot, don't have heart murmurs. There you're mainly going to pick up someone with a valve problem, which again is you'd want to know that and screen that patient. But something I want to talk about, and this is controversial here in the U.S., but I would want to talk about a little bit about how we differ from really the rest of the world, particularly Europe, in how we screen athletes. In Europe, and we'll talk a little more going back to the 70s. Some countries have been screening, EKG screening, and back in 2004, the European Society of Cardiology and the International Olympic Committee recommended ECG screening of all athletes. The U.S. committee still follows our guidelines here and does not, at least officially, screen EKG screen athletes. Nonetheless, at the professional level, most athletes are EKG screened. 2007, the American Heart Association, whose guidelines we typically follow, addressed this issue, and they really didn't talk about this being an issue of saving lives, because obviously screening will save lives. It's an issue of cost and infrastructure. As we talked about, in the United States, there's 5 million or more student athletes competing, and the United States at this time probably doesn't have the infrastructure to effectively screen every patient, every athlete. And what is the cost involved, particularly with the false positives? We have a different patient population than Europe. Many of our athletes would probably have more likely to have abnormal EKGs, or at least what would be read as abnormal. So it's a controversial issue. Nonetheless, I thought you might want to hear a little bit about the data. There are, as we talked about already, most of the diseases that cause sudden death can be detected with a screening EKG. And that includes hypertrophic cardiomyopathy, which is, again, about 1/3 of causes of sudden death in our population here in the United States. The problem is that normal athletes, especially highly trained athletes, will have abnormal EKGs. They'll have what's called ST elevation. They'll have ST changes. They might have some minor arrhythmias, meaning skip beats. So if maybe not a highly trained cardiologist familiar with sports medicine or electrophysiologist might read many of the athletic screening EKGs as abnormal. And that's one of the issues the American Heart Association got into, is what would you do with all these false positives? Would you be testing all the patients like they do in Europe? Most of the changes are fairly benign, though. Like any runner is going to have what's called bradycardia, slow heart rate. I've seen actually patients with very low, what we call junctional rhythm at baseline. Many of them have what's called heart block, where the EKG, the top chamber and the bottom chamber aren't syncing up. The difference is with an athlete, if you either put them on a Holter monitor and run them, or just run them on a treadmill, which is a low-cost type procedure, their hearts will sink right in. So it's really due to what we call vagal tone. They don't have a problem with their heart. They simply have high vagal tone. So if you give a runner a simple EKG, running EKG, Holter monitor or something, you'll immediately see that there's no problem with their conduction system, whereas someone who has marked cardiomyopathy, it's not going to improve. And that's really kind of going to be the bottom line of the next few slides, is that athletes, things will improve with exercise, whereas someone with a congenital problem, they won't. So for EKG screening, again, the typical problems you'd see, like slowed heart rate, a little bit of AV block, those things, many would suggest you just kind of consider those normal for athletes, and they should not need further screening. They could immediately be cleared, but people who have bizarre EKGs or pathologic changes probably need further, would need further testing, whether it's a simple echocardiogram or an evaluation by at least an internist or their family doctor or cardiologist, but some sort of further evaluation beyond the simple screening physical. The problem with an athlete, again, not really the problem, but one of the issues with training, high-level training, is that their hearts will change. And this has been known for years, that particularly weightlifters and endurance runners, their left ventricles will modify to allow them to compete in these sports. And the ones, especially at the elite level, they're probably genetically a little different than the rest of us, and that allows them to do these things. So they will have large hearts that could push a lot of blood around, because otherwise they wouldn't be able to do things they can do. So they will thicken, their hearts will thicken, their cavities will dilate to allow just make a very large pump inside their body to get that blood moved around, to give them the oxygen to do the things they need to do. And particularly rowers, swimmers, those types of athletes will have very dilated hearts compared to a non-athlete. And again, for a weightlifter who's doing a lot of anaerobic exercise, just like their muscles are hypertrophying in their arms and their chest, their heart's hypertrophying too. And again, if you screen these patients, you're going to see changes, you're going to see abnormal EKGs, abnormal echoes. So the art is to differentiate those patients, when they be, not really patients, but those athletes from a normal athlete, a normal heart. And again, there's a lot of data. Italy has been probably one of the earliest pioneers in looking at this, so there's a lot of Italian data, but Italy looked at many of their elite athletes, and big picture of this slide is just to tell you that they screened thousands of athletes with dilated hearts who were elite competitors, and found that none of them had really any abnormalities in terms of cardiac conduct. When they were followed over 5 years, they all did well and had no development of hypertrophic cardiomyopathy. So the issue, again, is to try to screen out the elite athlete from someone with a congenital problem that may cause them a risk down the road. And there is a gray zone when you look at echo screening. So again, if you were to just send someone blindly for an echo, it might be read as an abnormal echo in a normal athlete, just because they, particularly a weightlifter, might have a very thickened ventricle. So we do have to have other criteria, and again, this gets beyond simple screening. Someone who hits that criteria probably needs advanced evaluation before you allow them to compete. And again, this is really more on the physician cardiology side, but there are areas where we can look at the type of hypertrophy they have on an EKG, what their cavity looks like. Again, an athlete will have a very dilated cavity to allow the blood to pump, whereas someone with a hypertrophied heart will have a small cavity because it's really all muscle and it's abnormal. It's not pathologic condition. And the filling pressures, the amount of blood that gets into the heart, those sort of things, how they'll do on a metabolic stress test. And really the most important, which is in the literature, is deconditioning. Now, that's the last thing an athlete wants to hear, but if someone were really pressed to the wall, they couldn't determine what was going on. Now, with PET scanners and MRI scanners, usually we probably could get beyond that, but when the rubber hits the road, if you have to, you can make an athlete stop exercising. A normal heart will, just like their arms and their legs and everything else will shrink down, their heart will shrink down again, back to a normal heart. Whereas someone who has a congenital problem, that's not going to happen. It's going to stay the same or get worse. So if you had an athlete where you weren't sure, you might have to make them sit out a season and decondition just to see what the heart does. But that's not going to be your typical. Usually there's other testing that could differentiate that. So again, getting back to the basics, the whole point of screening is really to find someone who might be at risk of dying suddenly, catch them before they die, because unfortunately for many of these conditions they're asymptomatic until something tragic happens. And again, we're screening millions of people in the United States looking for problems that occur in a fraction of a percent of the population, so it is a difficult process. In the 70s, Italy did mandate screening of all athletes, and the studies have been done. They screened, again, these are much smaller numbers than we have here in the U.S., but they screened 33,000 athletes in the 70s through the 90s. They disqualified only about 2%. The most commonly, they were disqualified for either rhythm abnormalities or hypertrophic cardiomyopathy, valvular heart disease, and all the disqualifications kind of followed along with the prevalence in society, so there really were no surprises. EKG evaluation, however, in these studies was shown to be highly specific, highly sensitive. And again, that goes along with most of the diseases you're screening for. Usually you'll pick up on an EKG. Further data looking into the mid-2000s looked at a little more, over 40,000 athletes, and found essentially the same data, and their conclusion was about 89% of sudden deaths had been prevented by doing the screening process. Therefore, the really only difference, European versus American standard right now, is the EKG. Otherwise, we're pretty much doing the same things. And in Europe, if someone does have an abnormal EKG, they are moved on to further testing, be it echo, cardiac consultant. So the algorithm simply is that athletes are all screened, and if any aspect of the screening is abnormal, particularly the EKG or physical exam, family history, they're moved on to further testing, and then if the testing is normal, back into the allowed to compete. If it's abnormal, obviously they're kept out of training, but more importantly, they're treated for their conditions. Recent study, this hasn't been published yet, it just came out in April, but University of Washington kind of took the Italian approach and screened about 1,300 athletes. And they did find 6 athletes who would have potentially died suddenly if had not been screened. They looked at their sensitivity and specificity of their data and found that medical history alone was sensitive, but not very specific, but not all that sensitive. And they only picked up would have picked up a third of the cases. The physical exam was not useful at all, which again goes along with the types of diseases you're screening. And ECG screening brought that up to 100%. Again, now looking at that, they screened over 1,000 athletes to find 6 patients, but if you prevented 6 sudden deaths, I think, probably worth doing. So sudden death in athletes, again, kind of putting it all together. This is a rare problem, and we do have a large number of athletes competing, which is why it is a problem. Simple screening done in the United States based on guidelines from the American Heart is sensitive, but not as sensitive as we probably need. There is evidence from our friends across the ocean that further screening with EKGs would be beneficial. And the risk we have in America is the false positives and what to do with those patients, particularly when you get into the areas of cost. That's really the limiting factor, I think, at this point in time. Nonetheless, if we look at the Italian data and we kind of extrapolate it, even though there are differences in populations, we would assume if there's 100 patients a year, 100 children, high school athletes a year dying suddenly, maybe we could prevent a good portion of those. And that's all I have to say.